everyone. Welcome. And thank you for everybody joining us this afternoon for another segment of our Healthy Moms and Strong Babies seminar series. My name is Erin Jones, and I'm the Director of Legislative and Strategic Council here at the March of Dimes, and I'm filling in for your usual host, Stacey Stewart, who couldn't be with us today. Today is World Prematurity Day. This day is observed around the globe each year on November 17th to raise awareness of preterm birth and the concerns of preterm babies and their families worldwide. Approximately 15 million babies are born preterm each year, accounting for about 1 in 10 babies born worldwide. The March of Dimes released our 2022 report card on maternal and infant health in the US, which represents the state of maternal and infant health in the United States, including Washington, D.C. and Puerto Rico. The report examines maternal and infant health and how states are progressing towards the United States Department of Health and Human Services Healthy People 2030 objectives. This year, the report card also includes some new sections to describe March of Dimes' organizational programmatic initiatives, as well as advocacy efforts that are happening in the states to improve the health of moms, babies, and families. The report card builds upon our Maternity Care Desert report, which we discussed in previous Healthy Moms, Strong Babies webinars. The report card numbers point to several alarming trends, which we are going to take a deep dive into today and discuss. The United States earned a D+ grade in preterm birth, with the preterm birth rate increasing to 10.5%. This is the worst rate the March of Dimes has ever reported. Furthermore, the 15-year high in preterm birth rates disproportionately affect Black and American Indian, Alaskan Native women and babies, and persistent disparities continue to exist among other demographics. For instance, Black and Native American women are 62% more likely to give birth preterm, and their babies are twice as likely to die than their white counterparts before their first birthday. So what are driving these factors behind these numbers, and what can be done to reverse the trends? And what we will be discussing today with our distinguished panel and experts and advocates is exactly that. Before I turn it over to our panelists, I'd like to point to you where you can download the report and read the report, helping to stay informed about the state of maternal and infant health in your own community, in your state, and across the United States. There is a link to the 2022 report card in the chat, and we'll share this link again at the end of our program. So with that, I'm going to start introducing our panelists. Our first panelist is Dr. Jakiba Henderson, who is our Senior Vice President and Interim Chief Medical Officer and Health Officer here at the March of Dimes. And no one can speak more to the data that's contained in the report than Dr. Henderson. She has been doing lots of these across the country these days. So we're happy to have you, and thank you for coming again today. We also have Billy Hamilton Powell, who is a certified nurse midwife. She is the Director of Midwifery Services and Mobile Health at the University of Maryland Capital Region Health. She comes from a long line of midwives, as both her great-grandmother and great-great-grandmother were midwives back when Black people were not welcomed at white hospitals. She is very familiar with the relationship between maternal health and social marginalization, which is why she has dedicated her career to helping women who are living in maternity care deserts. Thank you so much for coming, and thank you for all the work that you do, and we look forward to talking to you more, Billy. Next is Amy Pisani. Amy is the Chief Executive Officer of Vaccinate Your Family, an organization whose mission is to protect people of all ages from vaccine-preventable diseases through education, awareness, and access to life-saving vaccines. As a leading authority in vaccine advocacy, Amy has played an integral role in settings and standards of immunizations in the United States. It is no exaggeration to say that her work has quite literally saved lives. It's an honor to have Amy here with us today, and we're going to talk to her a little bit more about vaccines. And finally, we have Diana Harado, who is the March of Dimes NICU Family Support Coordinator at the Children's Hospital of Orange County. In her role, Diana provides NICU families with education, support, and information, and she empowers families to take care of their babies with the team while they're in the NICU. She serves as a guide to their NICU journey. She provides patient and family resources and supports their emotional needs through the roller coasters of being in a NICU So we're happy to have Diana with us here today. So now that you've met our panelists, let's get started. And just as a reminder, I encourage everyone who's joining us in the webinar to use the Facebook comment section to send in your questions, and we'll do our best to address them throughout the conversation. And we'll be providing resources at the end of our comment section and, in the comment section, as well as at the end of the webinar. So let's get started. I'm going to start with you, Dr. Henderson, and let's dive right into the report. As I mentioned earlier, the US earned a D+ grade. And we've previously discussed that among industrialized nations, our country has shocking high maternal mortality rates. So I'm going to give you this opportunity to tell us a little bit what we found in the report.
So, we often talk about, the bad statistics in our country, unfortunately, and I'm sad that on this World Prematurity Day that we don't have better news regarding premature births in our country. Before starting this conversation, I think it's important that people understand the definition. So when we talk about a preterm birth or prematurity, we're referring to babies that are born too soon, which is less than 37 weeks gestation. And in this report, that rate has increased to a 15-year high. The last time we saw a peak in the preterm birth rate, even close to this rate, was in 2007. And unfortunately, along with the increases, we have seen a widening in the disparities in preterm birth. Out of all of the states in our country, we talked about the grade for the US. The US got a grade of a D+. But when we look at all of the states across the country, 45 states and DC and Puerto Rico had a worsening of their preterm birth rate and grade on this report card. And I'm a little frustrated that we're still talking about bad outcomes, but we have to understand that preterm birth is a very complex issue. There are so many factors that contribute to a baby being born too soon. For example, we just came through a major pandemic, and we know that there were issues with disparities that were magnified during the pandemic. We also know that there are conditions that people have before they enter pregnancy that may contribute to their babies being born too soon. In our country, our population of moms that are having babies are growing older and tend to come into pregnancy with other pre-existing health conditions such as high blood pressure, diabetes, kidney disease, and other things that also would contribute to a baby being born too soon. But then when we think about the pandemic and the impact of the pandemic, we can't deny the fact that the pandemic changed how we do things. It changed completely how patients accessed care. It also changed how we provided care. And when you think about all of the increased stressors and reduced workforce, reduced resources, and also the stress of not having the full information around the impact of COVID right away at the beginning of the pandemic, and the pressures to get patients in and out of the hospital, I'm almost certain had an impact on how we delivered, how soon we delivered, and the threshold of making that decision of whether a baby needed to be delivered or not. So there are a combination of factors that we believe contributed to the increase. There was a slight decrease last year, and we were guardedly optimistic. But when we looked at the numbers across racial ethnic groups, while the overall preterm birth rate decreased a slight bit last year from 10.2 to 10.1, we saw an increase in certain groups, particularly among Black mothers and American Indian and Alaskan Native moms. And so because of that increase, I had anticipated that we would see a further increase this year.
So you gave us some indication that this isn't an easy thing to solve and that it's complex. And there's multi-factors as to why a woman might have a preterm birth. But can you talk a little bit about, are there any solutions? Is there anything that hospitals or public organizations or legislators can do to kind of address this crisis?
Absolutely. So I mentioned a lot about the preterm birth rate and what we talk about around preterm birth in the report, but I don't want to fail to mention the other items that we cover in the report, including a rising cesarean birth rate, including issues around access to prenatal care, although we did see an improvement in access to adequate prenatal care. But when we start to think about solutions, we have to really try to zero in on what the drivers are, what we think are leading to these worsening rates. And while we don't have the exact answer, there are some things that we know work. For example, we know that access to high quality care is very important for the best outcomes during pregnancy. And in our most recent report, Maternity Care Desert Report, we show that over half of counties in our country have either limited or no access to maternity care. And that includes maternity hospitals, obstetricians, midwives in over 50% of counties in our country. We also know that even if there is a provider available, that people need to be adequately insured. So our organization has been advocating extensively around expansion and extension of Medicaid, knowing that over 40% of pregnancies are covered by Medicaid in our country. So having good access. We also know that because what was magnified during the pandemic was shortages in the workforce and staffing. We need to expand our workforce, the people that are so important to take care of moms in this country. And every other country that has better maternal outcomes and infant outcomes than we do has large midwifery workforces. And so we are advocating for an expansion and diversification of the midwifery workforce. And then other solutions include, having increased access to doula support. There is evidence that shows that having support during pregnancy, during labor and birth, and postpartum improves outcomes as well. There are a myriad of other solutions that are potential solutions. There's still much to learn about the causes around preterm birth, particularly spontaneous preterm birth. And so we need to do more research and invest in more research to increase our knowledge around those potential interventions to prevent those births.
Thank you. I'm going to switch now a little bit to parent education. And I know that March of Dimes just launched a brand new app. So I'll give you an opportunity to talk a little bit about Compass, which is, and talk a little bit about what it's supposed to do and how it helps parents.
Yes, I'm so excited to talk about Compass. So it is so important for moms and families to feel completely empowered, to feel supported during and after their pregnancy. And so this app that we recently released is a resource for moms and for families, whether you're planning to become pregnant, while you're pregnant, and even after, providing very important information to help you in your decision-making, to help you to know what questions to ask your provider. There are also important resources that are available. And in addition to the resources, we have communities where you can reach out and receive support from people just like you, looking for the same answers. And then there's an opportunity to get support, particularly, for example, if you had a baby that was born preterm and you need information about what it's like, what do you have to deal with when you have a baby that needs intensive care in a neonatal intensive care unit. But overall, I'm just really excited about the app because it's an opportunity for moms across the country to have access to information, to resources, and also support.
Thank you. And don't go anywhere because we'll have more questions for you, I'm sure. So I'm going to switch over to Billy and have a chance for Billy Hamilton Powell to talk to us a little bit about what's going on with the project that she's working on. And Billy, I know that you serve close to 7 million women in the world who do not have, they're of childbearing age, but they don't necessarily have counties where they have access to maternity care, and that you have a solution. So can you talk a little bit about what you're working on and how you can help improve birth outcomes?
Right. I'm sort of going to piggyback what Dr. Henderson said about solutions to help with prematurity. I run the mobile health clinic called the Mommy Baby Bus, which is supported by the March of Dimes. We have to address women who need to have prenatal care to start from the very beginning so that we can make sure that prematurity is stopped ahead of time and address those preventive health care issues so that we can have healthy birth outcomes. So as we know that there are some counties that have decreased places in which women can get prenatal care, or these women do not have insurance to be able to get prenatal care. So disparities in being able to get prenatal care just isn't in rural areas. They can be in urban areas as well. So in our nation's capital, believe it or not, we have areas in which women cannot get sufficient prenatal care, just like in rural areas. And so what we're doing now is taking the prenatal care to them. Instead of having them come to the office, we're bringing prenatal care to them, whether they have insurance or not, whether they're documented or not. We need to make sure that they're getting that adequate upscale, high-rated prenatal care to address the issues that they have. When we first started doing prenatal care for these women pandemic, we were just doing low-risk patients. But now, post-pandemic, we're realizing that these women need to have upscaled care for them. We needed to initiate more maternal fetal medicine because the problems that we're addressing now for these patients are more high-risk issues in there. So now we have incorporated other avenues for these patients to be taken care of. So we have incorporated preventive health care with family medicine. We've incorporated maternal fetal medicine so that they can have the full scope of care that they would have in what we call the brick and mortar buildings. We have ultrasound capabilities, referral basis for them so that they could get this care so that we can address the ability to reduce prematurity in these women. Because just like Dr. Henderson mentioned, we need to address diabetes. We need to address hypertension. We need to address the advanced maternal age mom. We need to address the mom who's had a C-section. And can we now do, which is called a VBAC, a vaginal birth after cesarean. And we also need to address a big one, obesity in women in these pregnancies that can, again, add to prematurity. So as our bus goes out to these communities, we're addressing all these different disease processes to make sure we're trying to get better outcomes for these women. So we do have midwives on our buses that provide this care. And we're incorporating family medicine as well to continue on the continuum to address these disease processes in order to take care of women. We also have been fortunate to be able to incorporate adaptive services to get them enrolled in healthcare insurance programs, to help with food services, lawyer services, whatever they may be, in order to also address those social needs as well. Because even though we might not think about it, that can also interfere with possible prematurity of birth as well. Also talking about breastfeeding to help with, just in case we have a premature baby, because that's going to help with that survival of that premature baby. So we're not only looking at pre-birth, but post-birth as well on these babies, on these moms, and making sure that they have care before the birth and after the birth, and understanding that they can still continue with their care, with their postpartum care and their GYN care on this unit as well. So we're making sure that not only just a pregnant mom is taken care of, but a woman is taken care of so that we can reduce the need of having an additional premature birth for the woman after she has the baby.
Great. Wow, you guys are doing a lot. So I'm going to ask you one more thing. I think you kind of alluded to this when you were talking. Dr. Henderson mentioned it. It's also in the report that we look at cesarean births and looking at, while we know that sometimes cesarean births are absolutely necessary, what are you doing through education and just talking to women about having and advocating for their own safe birth through the mobile bus? Are you having opportunities to talk to women about cesarean?
Absolutely. Especially those women who do not know that even one C-section does not mean a repeat C-section for them. Understanding what is normal weight gain in a pregnancy. If you have diabetes, how to control the diabetes so that we do not have what is called a macrosomic or a big baby, which can increase the possibility of having a premature baby or possibly a big baby that would not be able to have a vaginal delivery. We've talked about controlling hypertension, which could end up having problems with the placenta and therefore a premature baby with preeclampsia, or what we call superimposed preeclampsia, where you have hypertension and another disease process on top of that, and having an early baby with that. So yes, we really are into educating the patient on those preventive processes throughout the pregnancy in order so that we could have a healthy baby. Also, what we called preconceptual counseling. So a woman who comes in for her GYN care, if she's obese, let's talk about what we prepare our bodies for the pregnancy so that we do not have to have a C-section in the next pregnancy. How do we labor through the delivery so that we can make sure that we can have our bodies prepared for the birth? How do we do natural processes to get our bodies prepared for a vaginal delivery so that we're progressing through the labor process so that we are not considered failure to progress and increase the risk of a C-section? So we can also talk about going to a hospital and they're saying, oh, let's just go ahead and induce you right at 40 weeks and say, instead of saying, let's talk about, waiting and do antenatal testing and seeing if our bodies will go into labor naturally. So, talking about birth plans and what our bodies can do and preparing for the labor process can help the woman really know what her options are. And then if we do an induction, talk about the different processes of induction of labor. So she's fully aware of what those processes are. So she can be a very informed participant in her labor process.
Wow, that's amazing. And I appreciate that you're telling us all these things that are being done on a mobile health unit. So this is happening right in their neighborhood, which is fantastic.
I want people to understand that just because the word mobile is in our office does not mean that it is less than what she gets in a brick and mortar building.
Excellent. Thank you, Billy. I appreciate it. And don't go anywhere. We'll have more questions for you as well.
Okay.
Now, building off of what Billy was just talking about, and you said it, great about not just talking and caring for the pregnant woman, but also the woman, right? Making sure that she's healthy so that at some point in time, if she does decide to have a child, that she is prepared for that pregnancy. So I'm going to switch over to Amy Pisani and talk a little bit about prevention, which is something that's near and dear to me, is talking about vaccines and knowing what's going on in our country today, how critically important it is that we get the message that they're safe and they're the best way to prevent disease. So I'm going to give Amy an opportunity to talk a little bit about, in our report, we talk about some of the dangerously low rates of maternal vaccinations. And so can you talk a little bit about that, Amy, and what you guys are doing to address that?
Thanks, Erin. I really appreciate that. There's so many things that we can do to help pregnant people when they're preparing for birth. And I tell you, when I heard you say out loud, I read it, but when you said out loud that we are 10% early labor in this country, that's shocking. And it actually gave me the chills a little bit to think about. We're in such an advanced nation, and yet we're not able to provide the basic necessities to help people get through a full term. I almost went through a preterm labor. I was fortunate, privileged that I was able to work from home, and I sat on my couch for a month. But I know that's not the case for a lot of people. They can't take time off of work. They're in a situation where they don't know what the symptoms are. And I think that's that's the same type of social determinants of health that we've been clearly becoming aware of during the pandemic. All of those things that put people at greater risk of COVID, right? People kind of heard about it in the past. They knew that lung disease and diabetes and other ailments would make you more vulnerable to diseases, but they didn't quite make that connection over to, oh, I could get a vaccination to prevent that. So we are fortunate. There are a lot of things that are incredibly challenging. Diabetes prevention, very challenging issue, right? It's not a one-stop-fits-all kind of solution. But we do have vaccines that you can get during pregnancy that will help reduce the risk to yourself and to your child. And so we have vaccinations for influenza, of course, COVID vaccinations. There's a vaccination that you're to get in every pregnancy for whooping cough. That's called the Tdap vaccination. It's tetanus, diphtheria, and pertussis vaccine. And we will eventually be seeing a RSV vaccine come down the pipe, which will be incredibly instrumental, especially with the preterm babies that we're dealing with. So just to kind of not throw a lot of numbers out there, but we're in the midst of an incredibly bad flu season. We're going to start hearing about it more and more in the news, but those of us who are in the vaccine world are very, very concerned because the influenza vaccination rates are lower than they have been in about 10 years. And we've already seen 6.6 million illnesses very early for that level of illness. We've seen 48,000 hospitalizations already. I'm trying to think of all the, we've already seen 3,600 deaths. We've seen several children who've already passed away from influenza. And I think what's really critical to understand for this particular forum is the impact of influenza on a pregnant person. So, you know, obviously, there are a lot of things are growing when we're pregnant, and that decreases our lung capacity, and it puts strain on our other organs as well. And so a pregnant person who gets vaccinated against influenza, they actually reduce their risk of the illness by 50%. That's half the risk. And it reduces their risk of hospitalization due to influenza by 40%. And then that vaccination passes through the placenta, and it protects the infant. That infant is 70% less likely to contract influenza, and their hospitalization rate is 81% lower. I mean, that's just an amazing thing with just one vaccine. And I get really excited because I know many families that come to us and they have lost their children to preventable diseases. When it comes to whooping cough, we have several folks that have come to us. I'll tell you one story is Katie. Katie Van Tornhout had a baby. She was preterm. She had 5 miscarriages. Her baby was like her miracle. And unfortunately, she was in the NICU, and one of the hospital workers had pertussis. And the baby contracted pertussis, and the baby did die from pertussis. 80% of the time when a baby gets, or a child gets pertussis, it's from a family member, 80% of the time. So by vaccinating everyone around that baby, including the pregnant person, we can eliminate that nearly completely. So those are just a couple of the things that I'd like to talk about. And just one other thought is that you all have such amazing opportunities to reach people, and it's that community level conversation that has to happen, right? So we need the providers to all be giving presumptive vaccination for pregnant people. You're in the office, you should be getting your vaccinations. We also need the community health workers to be giving that message out. And in order to do that, they really need to learn what are the benefits of the vaccine, what are the risks, are they safe? We have to have good conversations, right? And then also, we are so lucky to have the WIC programs here in our country. So through the USDA, 7 million pregnant women and children are on the WIC program, food supplemental program. And it's for over 20 years now, those WIC workers have been assessing vaccination records of children. And when they're not up to date, they refer them to providers. And what a great catch-all to reach a high-risk community. They don't get a lot of credit for it, and we're just so grateful that they do it. But I think that's something that March of Dimes, you know, we all talk about collaborations, and I think that's a really great example.
Great. Thank you, Amy. I was going to ask you a second question, but you kind of did it. So I don't have to ask you the question, but thank you. But stick around because I'm sure we're going to have more questions for you. And lastly, I want to talk to Diana a little bit about how she works with NICU families and her own personal experience with NICU families. And what drew you as a person, having a personal experience, what drew you to the March of Dimes to become a NICU family support coordinator? So I know that was a loaded question, a whole bunch of things to ask.
Well, first, thank you so much for having me here today. This is, excuse me, such a special day in my heart for all of our NICU families and, of course, my own preemie. I did, like many, travel down the path of a normal pregnancy. Until then, it wasn't. I had seen some red flags. It was a Sunday. By Monday, I saw my OB. Tuesday, I was hospitalized. And by Friday, I was being rushed for an emergency C-section. And so I ended up delivering my daughter at 23 weeks, 5 days, at 535 grams, so roughly 1 pound, 2 ounces. And we had a NICU stay of about 3 months. In this discussion, another thought came to mind, and that was the fact that advocacy is so important in preventing preterm birth. Your own voice is so important. And this conversation reminded me of the moment of getting to that day, that Friday of delivery, and being very adamant that I said I was 24 weeks when the physicians were measuring me at 23. My daughter is 13 now. So 13 years ago, I'm at the cusp of viability. And it didn't mean anything to me. 23 weeks, 24 weeks, I didn't know what was going to come. And I was fearful to even ask what a delivery would look like and what the outcome was going to be. But I just remember being so adamant, no, I'm 24, I'm 24. And I just feel like thinking back now and knowing what I know now from being in the NICU for the past 6 years in my role, I think that changed, my voice changed the direction of care for my baby at that time. Had I let the providers, who of course I feel had all good intentions, but if I would have let them guide me and direct the care towards the 23-weeker, I think care post-delivery would have looked different if I was not so adamant and saying I'm 24 weeks. At 24 weeks, everything can be done to try to save that child. At least 13 years ago, that's where we were. But we had a 3-month stay, and in that time, my daughter had a pretty typical micropreemie experience. She had a PDA ligation. We had laser surgery for ROP on both of her eyes. But I think most importantly, the first therapeutic treatment she had was the administration of surfactant. For those who maybe aren't familiar with surfactant, it is a therapy given to the lungs so that those tiny lungs that weren't built to breathe at 23 weeks do have the capacity to expand and contract to be able to breathe on their own. So post NICU, once you kind of have time to kind of reflect and go through your experience, we really wanted to find a way to give back. And so as we learned about different organizations, we thankfully came across March of Dimes and really started to learn what March of Dimes does and how their advocacy really impacted my child's care. And we really learned how integral March of Dimes was in the development and support of surfactant. So learning all of that, March of Dimes quickly won my heart, and we became a mission family. And we said, whatever you need, however we need to help fundraise, wherever you need us to be, we will be there. And in that time, we learned about CHOC's partnership and contract with March of Dimes to implement a new NICU family support program within their NICU. And I quickly raised my hand and said, I want to do that. That is for me. I used to work for CHOC before I had my daughter. So it was just amazing how all of these things kind of lined up. I had been home with my daughter for 6 years because after the NICU, you know, it's the second phase of preemie life. It doesn't end when you walk out those doors. Your doctor's appointments, therapies, surprises. My daughter had a surgery a year ago, still related to prematurity. So the NICU journey doesn't end, but thankfully my NICU journey has brought me back to work with NICU families here at CHOC and with March of Dimes. So my heart is full, and I'm so excited to be here with you guys on this special day, in a forum, in a community that really gets it. So thank you for having me.
Diana, could you tell us a little bit for people who might not know what NICU Family Support does? What are your interactions like every day with families who are going through the NICU process?
Well, the Family Support Program through March of Dimes has a couple of different metrics that we really work on to meet. Education for our families, education for our staff, and really focusing on patient experience and family-centered care. So kind of bringing all of those components to really change the experience for our families. So that means making sure we're running our Family Advisory Council, that we are representing families in all of our work groups and initiatives here within the unit to make sure that we have real-time family voices implemented into all of our guidelines. But on an average day, my role entails to rounding on our families, especially focusing on meeting our new families, and making sure that they really have the knowledge and tools to start their NICU journey. The first couple of weeks, I always meet the families. I tell them, I know, it feels like you're floating. It feels like this is not real. Give yourself grace. This is a lot to take in. Be gracious with yourself. a lot of our families and moms, I know I did, feel very guilty, like they've caused this in some way. So we really talk about giving yourself grace, giving yourself time to feel like a parent, and giving yourself time to find your place and your voice within the care team. And then just really being that person that can say, I hear you, I know, and I'm here to validate what you're feeling. And it's okay to not know what you're feeling. And I'll usually, if appropriate, kind of share with them what my experience was. And I'll usually say something like, I don't know about you, but for me, I didn't know how to feel. And I remember feeling like I just wanted somebody to say, hey, Diana, guess what? This is the appropriate thing you should be feeling today. Because I couldn't even, it was like mud. It was sadness and joy and grief. And so, we talk about that. And grief within itself, we know can look like anger, like sadness. You could be withdrawn. You can be over the top, feeling like joyful at any given moment. So just being there to validate that, yes, this is a mess of feelings, and that's okay. And letting them know that we see it all and it's all welcome here. And so I'm really that person that can say, you know what, I can be your voice if you need to bounce off ideas, if you need to plan questions for your physician. If things aren't going well and you are too concerned to voice your concerns, let me know what they are, and I can just go and be that person that brings them up on your behalf. So just really being there, and also making sure that we are providing opportunities where families can gather and meet each other and really provide some very organic peer-to-peer support within each other so that they can start to build a sense of community amongst the other families in the unit.
Great. Well, it sounds like despite the fact that they're probably in a very scary situation, that they're very fortunate to have you and your experience if they happen to be at the NICU at CHOP. So thank you. It's very nice to have you speak
it's my
a little bit.
pleasure.
Thank you. So we will open it up. If anyone has any questions from our audience, if anyone has any chat questions that they want to put in the chat in the Facebook comment section, we'd be happy to take some of those questions. In the meantime, I've got a bonus question for everybody, and it's a loaded one, so I'm going to apologize. But from each of your perspective, from what you just talked about, think about what in your mind is the thing that we should be doing in the US to reduce preterm birth rate. Is there a key thing that you think that could happen?
Well, I will say that immunizations there is some research that's showing when you get an influenza vaccination, it actually does help reduce preterm births as well. And so that's one thing we could immediately be doing.
Thank you, Amy.
I think addressing education throughout each visit that you have, I think it's very important, and knowing that you can empower your women about their birthing experience.
Thank you, Billy.
I would piggyback off of that. I feel like we really need to bridge the gap between our providers and our families. Not that our, providers aren't well intentioned, but I just feel like at least what I see within our NICUs, we have a lot of families who feel I'm going to say insignificant compared to our staff, because there is that gap in education. And I mean, coming into the NICU, whether you speak English or not, you're still learning like a second or a third language, right? NICU language. So I wish we could have an expansion of support personnel within, our OB offices, somebody where our families can feel like they could build that rapport, voice their concerns, and be that bridge to our providers who, like I say, are so well intentioned, and it's at no fault of them or our families, but we just need to bridge that gap so our families really feel like they can voice any concerns that they have, instead of just letting providers kind of direct the care, really incorporating our family's voice and really letting them be the guide to their own experience.
Thank you, Diana.
And then I have some input regarding trying to prevent babies from even having to go to the NICU. So when we look at the data, about 3/4 of all these preterm births are what we call late preterm births. They happen between about 34 weeks gestation and 36 and 6/7 week gestation. And we call them late preterm births because these babies overall tend to do a little bit better than those that are born earlier than 34 weeks, but they still experience complications such as issues around lung development, infections, and other complications needing to be in the NICU, and even have an increased risk of death. And there is data that shows that the preterm births that happened between 2014 and 2019, and actually since that paper was published, they've done additional analyses showing up through 2021 that a large, if not all of the increase we've seen is due to increased obstetric intervention. So moms who've had C-sections without having been in labor, and those that were admitted for induction of labor. While we don't know what the causes of those or the reasons why those decisions were made, we do know that the decision to deliver is a huge contributor to the preterm births that we see. So one, we want to make sure that mom's health is optimized. So that decision over maternal health is not a reason why they're being born too soon. And then we need more information around the understanding the pathophysiology of preterm birth for spontaneous preterm births. We need more research to be done to further understand that it's particularly for the earliest preterm births that have the highest chance of mortality and morbidity. So there are opportunities for us to learn more to be able to develop interventions to prevent that. And then I just want to encourage people that there are issues around just, you know, the social factors, access to care that we all can participate in improving by advocating for policies that support the health of moms and babies, making sure all moms have coverage for high quality healthcare and making sure they have access to high quality providers.
Of you for that loaded question, and I appreciate it because I think from each of your perspective that really gives us an idea of from where you work every day how you're preventing preterm birth and really trying to educate moms. We do have a couple questions that came in from Facebook, so I'm going to, one of them is for Amy around vaccines. It's more of a comment versus a particular question, but I'm going to do my best to make it into a question. How's that? But really, they wanted to ask a little bit about sometimes the smaller OB offices don't always have vaccines available because of storage issues. Where are other places people can get vaccines in the public or in their
So
community?
it depends on, of course, where you live. And I think one of the challenges is those social determinants of health. Yes, there are deserts. And if there's a provider, an OB provider desert, I assume there are also pharmacy deserts in there. And so if you cannot find a provider, I would recommend you call your public health department and they can help guide you. If I could just say one piece of great news for the year, that we did have a great win in the immunization and grow up. The Inflation Reduction Act, in that it now requires that Medicaid cover all routinely recommended vaccines, including those for pregnancy with no copay, and that's 42% of pregnancies in the US. So we have to raise awareness of that because you can cover it all you want, but if we're not telling people they're covered, then they don't really know where to go to get vaccinated. But come to our website, and if you have any questions or you can't find a vaccine, we'll find you one. Just come to our website or ask us a question.
Excellent. Thank you, Amy. We also have a question for Diana, and this is around if you are in a hospital that does not necessarily have a March of Dimes NICU family support program, how can you get one? That's probably a question for a whole webinar. But a quick answer, how can we answer that? You're muted, Diana. Oops, she can't hear me. We can't hear you.
Can we unmute her?
There we go.
Sorry about that.
There is a site that you can go to for more information, and perhaps in the resource page and information that we're sharing at the end, we can include that. I'm sure if you want to drop in what where you're calling from specifically, we can ask that your location gets a phone call, and we can set you up with somebody to discuss that further.
Excellent. Thank you, Diana. And one last question, and we'll be getting close to the end. I think I'm a little bit over, but we'll take one more last question from our audience here. They're asking a little bit about mental health and how maternal mental health plays a factor into support for moms, expecting pregnancy complications, postpartum outcomes, just the stress of maybe being in the NICU or having a child that potentially could be in the NICU. What are some of the factors and the risk factors for preterm birth and poor maternal outcomes around mental health? And I will open that up to any of our panelists who feel like they can tackle that in the last minute.
So I can quickly go through risk factors for preterm birth and mental health, and others can add in. We know that there are things that contribute to an increased risk of preterm birth. For example, the biggest risk factor is if you've had a preterm birth before. So if you've had a previous preterm birth, that puts you at high risk for another. If you have chronic medical conditions, or if you have conditions that you've come into the pregnancy with, for example, hypertension, diabetes, kidney disease, that puts you at increased risk of delivering too soon. If you're a smoker, that puts you at increased risk as well. And then the extremes of age, if you're very young and giving birth, or if you're very older, what we call geriatric pregnancies. I hate that term, but older moms and youngest moms are also at increased risk. And then there are other things. We often you'll see the list of risk, and you'll see a Black race as a risk, or other races of risk, but really it's not the race itself that's a risk. There are issues in terms of the structural and systemic racism that exists that puts these groups at increased risk. And I encourage you to take a look at our report card and look at those maps. And it's not a coincidence, the states where you see the highest rates. And I think that our country needs to come to grips with some of these social factors that contribute to the poor outcomes that we see. But those are just some of the things that increase your risk of preterm birth. In terms of mental health, there are lots of risk factors for mental health. If you've had a mental health diagnosis prior to your pregnancy, if you have a family history, there are also other circumstantial reasons that may contribute to increased risk for either depression or anxiety. And so what we do encourage you to take a look at, I'm just going to refer you to that Compass app. There's lots of information around mental health and resources for that. There's even a screening tool to help you to understand and know whether you're at risk for having mental health issues during and after your pregnancy.
And I would add, and then we do see within the NICU a higher rate of postpartum mood and anxiety disorders within our NICU families. And so we just, at least here in our NICU, we have information about postpartum and mood disorders posted within the unit. Our social workers are great at screening at different time periods within the unit to make sure that we are able to identify early on and link families to the services that may be needed. I think a lot of what we need to do too is make sure that our OBs and pediatricians have the resources to make referrals as well, because we do hear from our families sometimes that either a screening is not had or the screening is had, but then what comes next? How do we get that family actually linked to resources that they can start utilizing? But here within our unit as well, I think and across other units, I think it's important to have a peer-to-peer support program within your NICU. So that we can actually connect current NICU families with graduate families who have walked a similar path and can say, you know, this is tough. This is where I was. This is kind of what's coming next, and kind of just be the guides to the next steps on that emotional journey within the NICU.
Great, thank you. Well, we've come to the end of our program. I think this was very informative. I hope that people had a chance to ask questions if they want to, but if you didn't, as I mentioned at the top of the hour, that we will have a resource page that will come up very soon, and you'll have an opportunity to delve deeper into any of the topics that we talked about today. So as Dr. Henderson mentioned, we have the report card. It's Prematurity Awareness Month. It's also BlanketChange, all the advocacy efforts that Dr. Henderson talked about that you can also participate in. And there's also resources for Vaccinate Your Family. So if you are looking to get vaccinated and you don't know where to go, you can go on their website. They can help you direct. Or if you have questions about your vaccines, as well as questions about NICU family support. If you were looking for, how do I get a NICU family support in my hospital? We gave you the link for that as well. And if you're looking for information on the mobile health centers that Billy talked about, there's also a link to more information about the centers where you can ask questions. And then of course we have HRSA's hotline, which is fairly new, around an opportunity for women who have mental health questions to call a hotline and get services. So this has been an exciting opportunity for us today. And I thank all of our panelists for coming and staying a little later. Everybody knows me goes, I'm long-winded, so we went over a little bit, but I hope our viewers stayed with us. And thank you very much. And I look forward to seeing you all on our next Healthy Moms and Strong Babies webinar. Thank you.
Thank you, Marta Dimes. You're
Thank
wonderful.
you.